Welcome to the presentation regarding Chapter 54 for Module 4 of Nursing 150. For this presentation, we're just going to discuss the patient who has been injured and has a fracture, which would be musculoskeletal trauma. So specifically for this trauma, we're going to talk about fractures. Some expected outcomes of this presentation include explaining the importance of collaborating with the healthcare team when providing care for patients with fractures, apply principles of infection control when caring for a patient with a fracture, and identifying community resources for patients and their families that when they might need assistance at home for a patient with a musculoskeletal trauma such as a fracture. Planning discharge for these patients. Describe how to help the patient and family who might have a trauma that has affected their mobility and will affect their financial situation and their social situation. We're going to compare and contrast the common types of fractures, describe the usual healing process as well. So these are the main things that we kind of want to focus on throughout this presentation. Okay, so a fracture is a break or disruption in the continuity of bone that can affect mobility and sensation. These fractures can occur anywhere in the body at any age. All of the different types of fractures, most of them are on page 1144 in your IGGI book. There's some pictures that can tell you the different ways. These are all under the umbrella term of fracture, but as you can see, there's many different classifications. A complete fracture, for instance, is a break that is across the entire width of the bone, and so the bone is in two distinct sections. Incomplete fracture is the fracture doesn't divide the bone into two portions. It's not completely through the bone. An open fracture is pretty obvious. That means that it's also known as a compound fracture, but an open fracture means that there is an opening in the skin. So the bone has broken completely, and now a piece of the bone has actually opened the skin or disrupted the skin. So it's now become external, and that is a compound fracture. So it has broken the bone and the skin. The term pathologic fracture occurs when minimal trauma to a bone that has been weakened by a disease. So that would be a fracture that would occur secondary to osteoporosis. So if the bone is so weakened by osteoporosis that it kind of just fractures with a little trauma, then that would be a pathologic or spontaneous fracture. There's also something called a fatigue or a stress fracture, which results from excessive strain and stress on the bone. It's typically seen in professional athletes or people who train continuously. Stress fracture due to continuous stress on the bone itself from very persistent training. Compression fractures are by a loading force applied to the bone. So it's back fractures of vertebrae are very common sites for compression fractures. Most of these types of fractures, like I said, are on page 1144 in your book. And so make sure you review some of those pictures to help you get a visual of what we're talking about in these types of fractures. So these are some questions that you want to ask yourself when you are taking care of a patient with a fracture. So the first thing is, what should the nurse be concerned about regarding a patient with a fracture? Well, you're going to think about pain for sure, because it's a painful situation. So you're going to think about if the patient's in pain and get their pain under control. So pain definitely, and then you're going to think, what does this fracture how does it impact their mobility? So it's a safety thing. So if it's an arm, it's definitely going to impact some mobility as far as self-care. And then so just think about how it's impacting their mobility, and we're going to have to get them the tools that they need to make sure that they have assistance with their mobility. And then what complications could this fracture cause? Lots of complications of fractures. They might seem pretty benign, and typically they are, but there are a lot of complications that can arise from fractures. One of them is acute compartment syndrome. Fracture and trauma to a bone, typically the bones of the lower leg or the forearm, can cause swelling and pressure within a compartment in this extremity. And typically this occurs in the fascia, which is an inelastic tissue that surrounds a group of muscles, blood vessels, and nerves in the body. So inelastic is the key word here, because if there's swelling that occurs and it's not elastic, that means it doesn't stretch. That means that the pressure will build up in these areas, and they can cause so much pressure that they can reduce the circulation to the area and cause some significant damage due to no blood going to the tissue. A reduced circulation can cause some trauma to that area and actually can cause someone to lose a limb if we're not careful and we're not diligent to identify it as compartment syndrome in a timely manner. Tight, bulky casts are one risk factor for compartment syndrome or a dressing. So if it's pushing a lot of external pressure, so if they accidentally somehow get a dressing or a cast too tight on a patient, then it can actually cause too much pressure, a buildup of pressure, and can cause a compartment syndrome in that extremity with the cast. On page 1146 is a chart regarding compartment syndrome. Talks about the physiologic changes that can occur. So infection and necrosis could be the result of this type of syndrome, so we have to be diligent as nurses and identify this early. So this means that we are doing frequent pulse checks, frequent checks on that extremity that might have a bandage or a cast on. We're checking for circulation, for pain. It's pain that is definitely difficult to maintain. So if they continue to complain of pain to their arm that they have a cast on, and no matter how much medication you give them, they still are in pain, then you're going to suspect that maybe this cast is too tight. That's why they're having so much pain. You also want to check for numbness, tingling, things like that. That'll be signs and symptoms of compartment syndrome. So it's just important to make sure that we kind of monitor people with cast or bandages on to make sure that they don't get a compartment syndrome, because they could potentially lose this limb if we're not careful in identifying it early. And then you need to go on as a nurse to think about how is this fracture going to be treated. Most of them are treated with what is called a closed reduction, which means that we can put a cast on it and keep it in place until the bone heals. And if you notice on page 1145, the bone definitely is a bone that can heal. The younger we are, the quicker it heals. Young kids, they can heal up pretty quickly. They can only have to have a cast on for about 4 weeks and they're good. Older people, they do typically require the cast on longer for an external reduction. The bone will remodel. We make new osteoblasts, which are bone cells that can heal pretty quickly with an external reduction. Some fractures will not heal with simply an external reduction. They will require surgical management. This is called an open reduction. You may hear this referred to as an ORIF, an open reduction with internal fixation. That means they had to open the patient and they had to internally fix their bone that was fractured. Oftentimes these are the more complicated fractures, such as your open fractures or your comminuted, which are the fragmented ones. Those are the ones that are a little bit more difficult to fix and might require an open reduction internal fixation. Your displaced bone could also require such a surgery. If this occurs, then you will have to think about some of the nursing care that you will have to perform if someone has to have surgery. It's going to be a lot of those similar post-op things that we talked about. It's going to be pain, for sure. It's going to be monitoring that site where the surgery was. Is there bleeding? Is there signs of infection? Is there a lot of pain? How's their mobility? What are the orders for their mobility? What are we allowed to do with this site? If there's a cast or a boot on it, we're going to monitor for circulation and make sure it's not too tight, make sure it's not too painful. There's also such a thing as an external fixation system where they do have to have surgery, and we also put an external fixation device on it, which is putting pins and wires into the bone, and then the splinting system is on the external frame, which is outside of the body. There's a good picture of an external fixator on page 1155. So basically what this means is there are screws and rods going into the bone directly from this frame that's outside of the body. High risk for infection here. High risk for osteomyelitis here. So just think about all those things that would be your responsibility as a nurse. Pain again, cleaning the sites of the rods and screws, monitoring them for infection. Again, we want to get patients up and moving as soon as we possibly can, so we're going to have to be aware of what surgery they had, how quickly they can get up, and we can get them moving. We're going to monitor, make sure they don't get any pneumonia from their decreased mobility. We're going to monitor their eyes and nose, making sure they're getting enough fluids, things like that. So make sure you kind of take those things into consideration when thinking about fractures. This is just a visual. It's the same picture that's in your book regarding the common types of fractures. So hip fractures are the most common injury in older adults and one of the most frequently seen injuries in any healthcare setting or community. High mortality rate for your older patients. It's difficult for them to recover from an extensive surgery to fix their hip. A lot of it's prolonged immobility, and we all know that the older adult is definitely recovers slower and requires a little bit more help, some more than others. It kind of depends on their other comorbidities. But it is something that we will see frequently in healthcare. A lot of it's from pathologic fractures in the elderly. That's why they get them so much. This is just a good picture to kind of help classify that type of fracture. They will call it an intracapsular fracture if it's within the joint capsule. So you can see here, it means it's within the joint capsule itself here. That's intracapsular. They can also have something called extracapsular, and it means it's outside of the joint. So they'll have a fracture here, which could be from a fall as well. The femoral neck is here. And there's concern typically if an older adult has any kind of a fracture within the femoral neck, there can be a disruption in the blood flow to the area if there's a fracture in the femoral head. So it's always important that they check this out so that they don't have death of the bone or necrosis of the bone, which could cause some serious pain and mobility issues in a patient that has this. Your book has a good little box, Considerations for Older Adults, on page 1160. That talks about special considerations, talks about their visual acuity and hearing, just changes in their gait and balance and muscle strength can cause them to be at severe risk for falls and injury and fractures. Some medications such as antihypertensives, antidepressants, pain medicine can also put them at a big risk for getting these types of fractures. The most common type of surgery for a hip fracture, especially either one of these, it's going to be an open reduction, internal fixation. Well, they'll have to go in and fix and maybe put screws in for that hip fracture. You'll see a lot of these patients that have undergone surgery to repair their hip. You have to make sure that you monitor for pain for these patients. We have to be very careful with giving opioid medications to elderly patients. It can make them have adverse effects such as confusion, and they can fall again. I've seen that happen, unfortunately, in some older adults who are on pain medication for a hip repair, and then they try to get out of bed and they fall again. Something we don't want to happen, so we have to be very careful with that. We have to make sure that we get them up and moving, get their mobility, but we will have to follow specific orders regarding what they can do. For instance, we have to make sure that they do not fracture their hip, so you have to make sure that you keep their hip in proper alignment, typically preventing adduction of the hip. They have something called adductor pillows that they'll put within the patients. Now, a lot of these hip surgeries have been perfected. We are getting, a lot of the surgeons are getting new techniques that the patient does not have to have specific abductor pillows and such, because now they're doing like an interior approach. So we'll just have to be specifically making sure that we understand the orders for ambulation and mobility on these patients and make sure that we keep their hip in alignment. So it's just a picture of an immobilization device that we might be using for a patient with a fracture. Sometimes it's just to help contain it in alignment. A lot of patients have to wear this for a while after they've had it fixed with a cast, so it keeps it, just kind of keeps that bone stabilized as well. Again, it has to fit correctly. It shouldn't be too tight. If you see any compromise in circulation, you're going to make sure they loosen it. You also want to make sure you inspect the skin underneath it, make sure they keep it clean, and that they're not getting any skin breakdown from such a device. So this is a cast. You've seen people with casts. You know that there's lots of different types of casts these days. They're waterproof, they're purple, they're green, they're all kinds of different casts that they could have. Basically, it's the same basic care for all. You have to make sure that their circulation is okay. You're going to, like this patient right here, circulation areas you would want to check would be the toes, check their cap refill, check their color, check their warmth. I'm going to check all that stuff for your circulation. The other thing is they are going to have itchy, irritated skin underneath probably. They do not need to be sticking anything down in there to scratch it. If they do, they're putting themselves at risk for infection. So try to keep them from sticking hangers and pins and crazy stuff down in there to try to scratch their skin, because they're going to open themselves up for an infection. The other thing I want to talk about quickly is crutches, because people who have lower extremity fractures such as this person here might use crutches, a walker, or a cane. Crutches are typically used for people who have the upper body strength to do it. Older adults would have a hard time with crutches. And if crutches are used, they need to be provided to where they are fitted for the patient's height and their arm length. You can't just borrow somebody's, like I couldn't borrow somebody's that was 6 foot tall. I couldn't borrow their crutches. It's too tall for me. It wouldn't be properly fitted under my arm. You got to make sure that there's no more than 30-degree flexion of the elbow for the crutches. PTOT works extensively with patients to make sure they have the right crutches, but you just have to be educate your patients as the nurse that they can't just borrow Uncle Ted's crutches, because it needs to be fitted to them precisely for it to be effective in their mobility. As far as a gait with the crutches, you should have learned this probably in 121. That 3-point gait is usually the best way to tell someone to teach them to ambulate with crutches. So kind of review that 3-point gait for that. A walker is typically what an older adult will use for balance, and the physical therapy usually kind of helps them determine what size and what type of walker they need. They do need to have some strength in order to be able to use a cane, or a walker, sorry. Cane is usually used only for minimal support for the affected leg. So a lot of times patients who are on their well on their way to recovery and starting to have some mobility improvement, they'll use a cane just for minimal support. All right, so traction. Traction is something we don't see a whole lot of anymore, but it is a way that we can do sort of a reduction in alignment for a patient. It's the application of a pulling force to pull the body part correctly, to align it and rest it. It's usually the last resort to decrease muscle spasm as well, and it also relieves pain. So, very, very important for a nurse to monitor a patient who's in traction. Couple different types of tractions. Buck's traction is one of them, and it's called a skin traction. Buck's traction is skin traction. It's the use of Velcro boot. It's like a halter, and it's usually fixated on the affected leg. So it's external. Velcro halter or belt is secured to the patient's affected leg, and that is connected to a skeletal traction weight. So if it's skin traction, the things that you're going to monitor is the weight itself. Make sure the weight is not disrupted. It's a certain amount of weight that will be ordered by the physician. And the weight is designed to give that muscle and that bone just a precise amount of pull in order to keep it aligned and to rest it and prevent spasms from happening. So it needs to be not disrupted. It's ordered a specific way. We don't want people in there bumping it around, adding weight to it, hanging things on it, things like that. It's not a hanger to be hanging clothes on or anything like that. So you don't want that to happen because it'll disrupt it. Nurse's job, skin traction, called Buck's traction. Monitor your patient that they have all their needs met because their leg is connected to a weight. They can't get to anywhere. They need their needs met. You need to monitor their skin, where the skin traction is applied, and you need to monitor that the weight is not disrupted, that it's the weight that was ordered as well. You need to monitor them for pain, treat them for pain. And make sure, like I said, like all their needs are met, they're getting enough fluids, they're hydrated well, things like that. Page 1154, figure 54.5 is an example of a skin traction, and you can see that the boot is applied to that extremity, and it has the weight on the end of the bed there. It's commonly used for hip fractures. There's an action alert on page 1154 as well, talking about the weights. It's very important that you monitor those weights. They're not removed without a prescription. They should be freely hanging at all times. Tell everybody to leave them alone, basically. Inspect the skin at least every 8 hours for signs of irritation or inflammation. Whenever possible, remove the belt or boot that is used for skin traction every 8 hours to inspect under the device, if you're allowed to. Check it frequently to ensure it's proper functioning. We don't want to cause something, make it worse. We want to be able to monitor it effectively. The other type of fixation, and we already kind of talked about, is an external fixation, which is skeletal traction. Probably though, most people that you have seen just around and on television and stuff like that is something called halo traction. When somebody breaks their neck, they have the big halo looking thing on their head with the screws into their skull. That is a type of skeletal traction. So there's pins involved. There is an open in the skin involved. They're at high risk for infection. So what you're going to be doing with them is monitoring those sites where the pins go into the skin and into the bone for any signs of infection. Picture of an external fixation device. As you can see, the pins go into the skin and into the bone. This can look kind of ugly when you see somebody coming down the street with you in a wheelchair with this on their leg. It's an external fixator. Basically, it's for this super, super complicated fractures where the bone is just completely shattered. And they basically just have to keep these pins in it to hold the bone together until the bone can actually heal and develop itself. So monitor for signs and symptoms of infection all the time. You clean those pin sites, typically with just some saline. Clean around the pin sites and just monitor them for any drainage or anything like that. Again, just talking about the complications of fractures, shock can cause, from a severe fracture. A lot of times the pain can put them into shock, and just the release of a lot of endorphins and things like that can cause from trauma, could cause someone to go in shock. Not that common, but it could. Fat embolism, unfortunately, can be common. That's why you'll see patients on an orthopedic floor with fractures, especially of their long bones. The disruption in the long bones can release a fat embolism into the bloodstream that could cause very significant problems if it goes to the lung or the brain. That's why you'll see a lot of your orthopedic patients with very aggressive anticoagulation ordered for them. So they're always on some type of heparin typically. And they're, no matter their age or anything, they'll give them heparin, or Lovenox is another medication that you'll see to anticoagulate these patients to keep them from having any kind of embolism. Of course, they can get a venous thromboembolism as well because their mobility is decreased and affected. So again, aggressive treatment usually with anticoagulants to prevent any kind of clots to form and move that could cause maybe a PE, which is a pulmonary embolism, or any kind of fatal complication from any kind of clot moving infection. Of course, especially with your external fixations, your surgeries, people like that are going to be at risk for infection. Know to monitor for fever, increased pain, increased edema, redness, drainage, things like that. Chronic complications that occur is the ischemic necrosis, delayed bone healing. So arteriovenous necrosis. So just make sure that we monitor, again, like I said many times, about the circulation of a patient who has had a fracture or any kind of injury or surgery. You want to monitor that, the affected extremity, for color, warmth, and remember the 6 P's. These 6 P's are the 6 P's of compartment syndrome. These are the things that could indicate a compartment syndrome in a patient with a fracture. Pain, I don't know if I can write all these on here. Pain, paresthesia, which means numbness, pins and needles basically. Pallor, which means that it becomes pale. It needs another L in it. Pallor, paralysis. They can't feel it if it becomes too numb. Pulselessness. They are pulseless. And I love how they use the word poikilothermia, which in a weird sort of way just means that it's cool to touch. It's cooler than the other extremity. But I love how I gotta use this down here, poikilothermia. I love how they use this so they can add it in with a P. But basically what they're saying is it feels cooler than the other extremities. So remember those 6 P's. And that's peripheral neurovascular dysfunction as well. Pain, of course, we just talked about with the 6 P's, but we have to make sure that we monitor their pain and make sure that it's under control, so they feel like doing their physical therapy and things like that. Impaired physical mobility is going to impair people and disrupt their lives, so we have to make sure that we can kind of get them the resources they need to be able to continue the activities of daily living. It could be as much as making sure if somebody has a fracture where they could wear a boot so they could get around a little bit, getting them a walker, crutches, a cane, whatever they need to kind of help them maximize what they can do. Inadequate nutrition, we do have to consider. A patient who has a fracture is going to need increased protein in their diet, especially the elderly, especially people who, are at risk. So increase their protein, that helps them to reestablish that bone. Calcium supplements for those people who have a spontaneous fracture related to an osteoporosis. Increased calorie intake, that typically helps with healing as well. So just, kind of depends on the patient and their situation, but those are definitely the things that we want to make sure that they have enough nutrition to help healing. For Module 4, we will not cover amputations. It has been removed from Module 4, so this is in the PowerPoint, but I don't want you to be concerned about amputations in this chapter, in Chapter 54. So go ahead and skip over amputations. You will not be tested on that for Module 4. Again, you will not be tested for amputation in Module 4, so we will just skip this slide. And that concludes the presentation for Chapter 54, Module 4, Nursing 150. There are several slides following this presentation that you can review just to kind of assess your learning. If you look at this PowerPoint, just within the PowerPoint, not with a voiceover, in the comment section, you can see the answer to the questions that are presented here.